It's like I've opened my eyes again, and the colors are golden and bright again. There's a song in my heart, I feel like I belong. It's a better place since you came along. It's a better place since you came along.
Hello, everyone, and welcome to our seminar. We're so glad that you could join us again today. We have a very interesting program lined up for you today. I'm sure you're going to enjoy it. My name is Nancy Solomon, and I'm the coordinator for program development for the Institute for Patient Blood Management and Bloodless Medicine and Surgery here at Englewood Health. Today, we're going to be hearing a talk by one of our cardiologists, Dr. Aaron Schwartz, and he's going to speak on advances in cardiology for bloodless patients. In addition, our medical director, Dr. Margit Kaufman, will share with us information on how healthcare has changed and continues to change since COVID-19. We're also pleased to present to you today 2 interviews with our physicians. We're going to have Dr. Robert Simon, who's going to discuss the topic of urology for bloodless patients, and our advanced practice nurse, Jackie Pappas, will answer questions related to anemia management, which is an all-important topic for patients for whom blood transfusions are not an option. We'll also be interviewing one of our patients who had surgery here with our Chief of Surgery and Surgical Services, Dr. James McGinty. Many of our topics for discussion today are those that were suggested by you, our audience. So thank you for those wonderful suggestions. Please keep them coming. You'll have another opportunity to request additional topics at the end of this seminar today. Well, to get started, we'd like to hear from our manager, Ramon Correa, who'd like to welcome you to the program today. Thank you, Ramon.
Hello, and welcome to our program. We're so happy that you could join us today. Before we get started, we want to remind those in the area that if you need urgent medical care, Englewood Health has opened up several urgent care centers throughout New Jersey, where you can get quick, efficient care with Englewood Health physicians without having to come to the hospital. On this slide, you can see the locations of our urgent care centers. The facility in Jersey City is directly across from the Jersey City Assembly Hall of Jehovah's Witnesses at Journal Square, and will not only include urgent care, but continually be offering increased services. At full capacity in the near future, patients will be able to visit our physicians for all medical specialties at this facility. We hope that you enjoy today's program.
Thank you for that warm welcome, Ramon. We appreciate it. Well, next up, we're going to hear from Dr. Margit Kaufman. Dr. Kaufman is an anesthesiologist and intensivist whose passion is for providing excellent, compassionate, and evidence-based care to her patients. After joining Englewood Health, Dr. Kaufman became increasingly more involved with treating patients for whom blood transfusion is not an option. She became an active champion for patient blood management within her department and the hospital community. Currently, Dr. Kaufman is serving as medical director of the Institute for Patient Blood Management and Bloodless Medicine and Surgery at Englewood Health. She works closely on a daily basis with the clinical staff and local coordinators to ensure that patients who are part of our Bloodless Institute continue to receive high-quality care. Dr. Kaufman also continues to serve as an informal consultant for her department in matters of treatment and management of massive hemorrhage and coagulopathy. Dr. Kaufman has co-authored manuscripts and book chapters on topics related to anemia management and the critically ill patient. On both the state and national level, Dr. Kaufman is a representative to national committees for both anesthesiology and critical care medicine. We look forward to hearing from you, Dr. Kaufman.
Hello. Thank you so much for virtually joining us today. I'm very proud of the upcoming educational seminar that we will be broadcasting shortly. Our pivot to virtual community seminars is just one of the changes that we personally had to make starting in the early part of 2020. The past 2.5 years have certainly caused major changes in all of our lives, and anyone who has needed to interact with the healthcare system has been witness to some of these larger transformations occurring in hospitals, doctors' offices, laboratories, outpatient therapy locations, and countless other health-related sites. This transformation of our seminars has actually been extremely positive and successful. While we could normally invite a few hundred community members for a day of learning and education in person, now we are able to reach thousands of interested listeners across the globe. Some of our virtual seminars have been viewed by almost 20,000 people from 31 different countries at once, something we would never have been able to accomplish in a hotel ballroom in New Jersey. I would be remiss if I didn't acknowledge some of the challenges that we are facing in healthcare currently, including supply chain issues and staffing shortages. But when I speak to my colleagues around the country, it is clear that the leadership at Englewood Health is doing their very best to keep us prepared as possible. For example, there was recently a national IV contrast shortage, which was used during radiologic exams. Very quickly, our medical leadership communicated with the staff about the shortage, created policies and pathways to help identify critical cases who needed access to our limited supply, and also made themselves available to the staff for any feedback or questions. We had frequent updates, which made it easier for us to communicate with our patients and set expectations. And thankfully, after a few weeks, the crisis was resolved. The increased rate of retirements and changes in professions has clearly affected the healthcare field. But when I come to work, I know I will be working with a team of professionals who have chosen to stay and continue to provide excellent care to our community. Yes, some things do take longer than they used to, but the goal is still the same, to provide excellent patient care. But it hasn't all been challenging and difficult. There have been many positives that have occurred as well. The dramatic need to create telehealth programs is clearly one of the benefits of the pandemic. Recognition that there are some elements of healthcare that do not require an in-person visit has opened up avenues for patients who struggle with transportation or mobility. We have also realized the need for growth in certain areas to serve our community. Englewood Health recently had a large expansion in urgent care options. Our Cresskill site has been open for years, and as Ramon mentioned, more recently, new centers have opened in downtown Englewood, Fairlawn, and Jersey City. This integrated system helps maintain better communication amongst Englewood staff and reduce repetition of labs or studies because they are accessible within our new electronic medical record system. In the world of patient blood management, our expertise has become a valuable resource for the nation. As blood drives and donations plummeted, the U.S. was faced with its first national blood shortage. Leaders from Englewood Health and other institutions with strong patient blood management programs helped create educational materials and resources for our clinicians. Our experience treating patients for whom blood transfusion is not an option allowed us to provide expert advice on how hospitals could drastically reduce their need for blood products. I continue to have pride in how our institution meets its challenges and continues to focus on providing excellent patient care. On that note, I do hope that you're able to learn from and appreciate the wonderful knowledge our Englewood medical staff are planning on sharing with you today. Have a wonderful day.
Thank you so much, Dr. Kaufman. We really appreciate your insight on that important topic. Well, next up, we're going to have an interview. Our bloodless consultant, Sherry Ozawa, is going to interview Jacqueline Pappas. Jacqueline Pappas is one of Englewood Health's most experienced nurse practitioners in the cardiothoracic surgery department. For just about 5 years, she's performed as an integral member of the team. Prior to becoming a nurse practitioner, she had a strong background as a bedside nurse, taking care of patients in the cardiac intensive care unit. Currently, she primarily works in the outpatient office, preparing and treating open heart surgery patients in the perioperative setting. From the beginning, Jacqueline has been an advocate for bloodless patients for whom transfusions are not an option. The benefits of her extensive handiwork are evident as the perioperative process around an otherwise seemingly taxing circumstance becomes routine, making bloodless patients feel more at ease. Furthermore, she's taken a great interest in early detection of a variety of anemias within all of her patients who need cardiac surgery. She has now taken the approach to identifying and treating all perioperative and preoperative anemias for bloodless and non-bloodless patients as a standard of practice. A simple blood test is all she needs to complete her workup and tailor the treatment to the patient. Jacqueline follows the Englewood Health Hospital protocol for preoperative anemia optimization by giving certain medications with close monitoring and follow-up. She's able to safely treat anemia and optimize patients' hematologic status before their surgery to ensure a safe perioperative course and minimize the need for blood transfusion. Jackie and Sherry, we look forward to hearing from you.
So Jackie, thank you for taking a few minutes today to talk about a subject that I know is dear to your heart, and that's anemia in our patients. So let's start by talking about how prevalent anemia is and why should we be concerned about it.
So thank you for having me for this interview today. Anemia is very prevalent. I see most of our patients, about 80, almost 90% of our patients who require open heart surgery, I identify as anemic.
Wow.
So it's very prevalent.
A lot. So why should we be concerned about it? Many people don't think it's a big deal. So why should we worry?
I think that most patients don't even know that they're anemic. And just from a blood test, a simple blood test can identify that. And I think that most patients don't see that from their blood work because either their physicians or their provider is not recognizing this as a problem, and to treat it, it's very simple.
So aside from what we might learn on lab work, some patients have symptoms, not everybody, but what might people look for in themselves?
I think the biggest symptom in anemia is fatigue, just feeling tired. Another big symptom is shortness of breath. So most of our patients already feel short of breath and fatigued, so that can also contribute to their overall symptoms on top of being anemic.
So I think that might be actually sometimes overlooked then because your patients have a lot of things going on, right?
Correct.
So maybe they don't recognize their anemia. What is your role? This is important to you. How do you play into managing, detecting patients' anemia?
My role in cardiac surgery as a nurse practitioner is to identify patients' anemia and be able to optimize the blood levels before patients are ready for their open heart surgery. So there's specific thresholds that I'm able to optimize patients to in order for them to be able to schedule their surgery so they're ready.
And you make it sound like it's something that just happens everywhere, but we know that it's something pretty special about Englewood Hospital, and your role is pretty special. So what if this didn't happen? What would be the consequences for patients if we didn't find their anemia and treat it?
Yeah, that's a great question. Patients, if they're anemic going for surgeries, any type of surgery, there are risks involved. And that includes blood loss just from their surgery, feeling even more symptomatic after their surgery. So being able to identify that early and treat it early on gives us a better and safer way to get patients through their surgeries.
That's a good point. It is a lot about patient safety. And it is interesting, too, that the medical literature points to the fact that outcomes can be much worse, clinical outcomes.
Correct.
If we don't take care of anemia. So a lot of the patients, people listening to us today are really interested in the topic of blood transfusion or avoiding blood transfusion. What is especially important for that patient population to know and think about?
So blood transfusions there are a lot of risks involved with receiving a blood transfusion. And those risks include infection, longer length of stay, prolonged ventilation, and even death. So I think it's really important for our patients to recognize, those risks involved.
And help us understand what you mean when you say prolonged ventilation, not a term probably that everybody knows.
Typically, we try to extubate or take out the breathing tube as quickly and early and safely as possible. And sometimes receiving blood products can prolong that process.
All right, so what might you say to a patient who's dealing with a provider, a physician or other provider, and they're not really paying much attention to or talking about anemia? What would your advice be to somebody like that?
My advice always is that you are your own advocate, and myself as well. You know, just being able to be in your chart, the electronic systems, you have access to your own charting, being able to look at those abnormal numbers and question that during your annual physicals, anytime you're with a provider, I think is the best opportunity to bring up those questions in order for you to get those answers. So always be your advocate for yourself is the biggest takeaway.
So you're an experienced advanced practice nurse. You have colleagues certainly at Englewood, but in lots of other places too. It's not common necessarily for people to pay that much attention to anemia. How would you perceive your time here at Englewood has sort of changed your perspective on this issue and bloodless medicine and surgery altogether?
I did not actually know much about bloodless medicine until I came to Englewood Health. And I have a great respect for bloodless medicine. I think it's a great practice, and I think that it should be more of a standard of care globally. And I think that it's great that patients are educated and know that this is an option. And Englewood Health is very accommodating with our patient population.
And what would you say to patients that might live a little bit further from Englewood? We don't want them coming in an emergency, obviously, but if they have some time to work with, but maybe they don't live next door, what advice would you give to patients in that situation?
I think that each physician in any department, any specialty, is very accommodating with patients who are requesting a consultation. Even my department, we offer consultations via Zoom. So, you know, it's if patients have a difficult time traveling to our hospital to be able to be seen, I think there's other options like telemedicine visits, and I think it's a great option.
That's great. And I do know that you are all very willing and able to often review records from patients that are shared by their care team, maybe in another location. How do you work together sort of as a coordinated team to make sure that we are really taking care of that patient from that first contact all the way through discharge and beyond?
So the information we receive from the bloodless department, we actually obtain all of our records in addition to the records we are reviewing already. If there's other specialties that patients see on a regular basis, we would like to review those last notes, last set of labs, and other information that would help us in order to come up with a great plan and understand the patient's medical history to the best of our knowledge.
So Jackie, in terms of anemia, there are some predisposing factors for our patients. What some of those might be?
I think some of the predisposing factors are hereditary, dietary, patients who are from different cultures, and I think women in general have a big predisposing factor for anemia.
We have people listening today from not just New Jersey, all over the United States and far beyond in other parts of the world. What would you say about the way that your team assists those patients, even that are not close by, in having this anemia managed in their pre-op time?
Yeah, we actually work closely with patients' hematologists if they already have that established, or we make sure that they're able to get in contact with a specialist who will continue to work with us, and also just know what our standard is to optimize patients preoperatively, making sure that they are receiving their iron infusions and getting Procrit or Epogen injections weekly, and making sure they have a close communication with our team to make sure we know where they are on track with their treatments.
Well, you make it all sound very easy, but we know there's a lot of work in coordinating patients' care. We really appreciate all that you put into these patients.
Thanks.
Well, Jackie, on behalf of all the patients listening and all of us here at Englewood Health, we really want to thank you for all the work that you put into taking care of these patients in general, but that special interest you have in anemia. And Taking care of it and treating it is really, really important, and you have contributed so many ways to helping these patients get better faster. Thank you.
Thank you. This is something that's near and dear to my heart, as you know very well. So I take my job very seriously, and I treat every patient like you're my family. So I would want everyone to have that same treatment, so across the board.
Well, thank you, Jackie.
Thank you, Jackie and Sherry. We really appreciated that interview. Well, next up, we're going to hear a talk by Dr. Aaron Schwartz. Dr. Schwartz is an interventional cardiologist here at Englewood Hospital and a member of the Englewood Health Physician Network. He is board certified in internal medicine, cardiovascular disease, and interventional cardiology. Dr. Schwartz is also certified in echocardiology and nuclear cardiology. He specializes in the use of catheter-based techniques such as percutaneous coronary interventions to treat heart conditions. He helped create the Coronary Chronic Total Occlusion, or CTO, program here at Englewood Health. Dr. Schwartz received his medical degree from Mount Sinai School of Medicine and did his residency in internal medicine and fellowships in cardiology and in interventional cardiology at Montefiore Medical Center in New York. Dr. Schwartz has particular interest in angioplasty, coronary artery disease, echocardiology, nuclear cardiology, hyperlipidemia, stents, acute coronary syndromes, percutaneous coronary interventions, adjunctive tools in cardiac catheterization, preventive cardiology, and cardiovascular clinical research. He is a fellow of the American College of Cardiology and the Society of Coronary Angiography and Interventions. Dr. Schwartz has won honors as one of New Jersey's top docs. We are proud to have Dr. Schwartz as a physician at the Bloodless Institute. We look forward to hearing from you, Dr. Schwartz.
Hello, everyone. We are glad that you're able to join us today for this program. For the past 10 years, I've had the privilege of working at Englewood Hospital. As an interventional cardiologist, I did training to be able to perform procedures on the heart. We do procedures such as angiograms and cardiac catheterizations to assess for narrowing and blockages in the blood vessels. We also have the ability to treat blockages in the blood vessels by ballooning them and then putting stents into them. As an interventional cardiologist, there is also a growing part of our practice that allows us to treat what is called structural heart disease, which encompasses valve problems and other structural issues of the heart. Today, I'm going to present to you updates in interventional cardiology. There has been new information when it comes to medications that we use. There have also been new procedures and new improvements upon procedures that we have been performing. The mainstay of interventional cardiology is the fixing and narrowing of blockages within the blood vessels due to buildup of plaque in the arteries. This is what is called coronary artery disease. The way we perform the procedure is by first inserting a small tube called a catheter, which allows us to inject a clear liquid called contrast and allows us to see the flow in the blood vessels. If we see a narrowing, then we can fix the issue with first using a balloon to dilate the blood vessel as close to back to its normal size as we can. We then insert a metal tube called a stent that keeps the blood vessel open and prevents itself from collapsing back on itself. The stents are typically nowadays coated with a medication that prevents the blood vessel from forming scar tissue and other plaque buildup within it. There have been newer and newer generation stents that are using thinner and thinner metal. The metal is usually a type of alloy that is not magnetizable, and therefore you can go into an MRI or go through metal detectors. As they have been improving upon the stent and the stent structures, we have been learning that the duration of medications that are needed may not be as long as we previously thought. The main risks of a stent long-term is that there will be a blood clot formed within the stent. We typically give medications that are called antiplatelet medications to prevent that clot from forming. The risk with these medications is bleeding. We usually start with an aspirin and then add on a second medication such as clopidogrel or ticagrelor or prasugrel. Historically, we have been giving these medications for a year after stent placement. Now, with more recent data, we know that we can stop the second medication after approximately 6 weeks to 3 months. We get the benefit of preventing the clot formation with reducing the risk of long-term bleeding. Once you get a stent, though, you will likely need to be on aspirin lifelong. For the procedure itself, we insert a catheter into one of the arteries, usually in the arm, by the wrist, or on the top of the leg. The artery on the arm is called the radial artery, and using it gives the benefit of having the patient be able to sit up sooner after the procedure, be able to walk around sooner, and there is a decreased risk of bleeding over using the artery on the leg. Only about 25% of catheterization procedures in the United States use the radial artery. At Englewood Hospital, most of our interventionalists are radial first, meaning we always try to use the radial artery except in cases where that is not possible. This gives the patient the best experience with the lowest bleeding risk. In the actual procedure, one of the biggest challenges is when there is significant calcification of the blood vessels. Usually the plaque that we are dealing with is a softer material, such as cholesterol and platelets that clump together. Over time, that plaque builds up in the artery and narrows it down further and further. However, with certain conditions, that plaque can now become much harder and become calcified. It makes it more difficult for the placement of a stent and the proper sizing of the stent. Thankfully, we have tools to deal with the calcium. The initial device that came to market was a device called the Rotablator rotational atherectomy catheter. This is a device that has a football-shaped tip to it, where on one end there are multiple microscopic diamond studs. The device spins at approximately 180,000 rotations per minute to break up the calcium into microscopic particles. Since then, there have been additional devices, one called the Diamondback orbital atherectomy catheter. This is a similar device which also spins at rapid rates and has a diamond-crusted stud to it that breaks up the calcium into particles. A third device uses a laser at the tip of it to cause cracks within the calcium and melt away some of the calcium. Most recently, a new device came to the market called the Shockwave device. This is a device that uses vibration to break up the calcium and make cracks within it. It's a small balloon that vibrates within the blood vessel and breaks up the calcium. This is similar to a procedure that is done for kidney stones. These devices fall under the category of what is called an atherectomy. They allow us to perform procedures on blood vessels that previously we would not have been able to fix or might have gotten a suboptimal result. It helps us avoid having to send people for open heart surgery. Another major challenge within the procedure is when we find a blood vessel that is completely blocked and has been that way for quite some time. Normally, when there is a narrowing within the blood vessel, we can use the channel to help pass our devices. However, when the blood vessel is completely blocked, we no longer have that channel. These completely blocked blood vessels are what are called chronic total occlusions, or CTOs. At Englewood, we have the tools to fix these type of blockages. The tools allow us to get through the blockage, around the blockage, or go backwards around the blockage to fix the blood vessel. I'm happy to say that Englewood has the only CTO program in northern New Jersey, and we have performed over 250 of these procedures. Another aspect that makes performing stent procedures more difficult and more dangerous is when the person's heart function is poor, or if they have multiple narrowings in all the major blood vessels or in the main blood vessel called the left main artery. These patients were typically referred for open heart surgery, or if they were turned down for open heart surgery, they were treated with only medications. In many patients, both of these options were not ideal options. For many patients, surgery might have been too high risk and they won't do well with open heart surgery, or perhaps the medications may not solve the problem that they have. Within the past few years, there has been a device on the market called the Impella left ventricular assist device. This is a small device that we can temporarily put into the heart through the artery on the top of the leg that helps the heart pumping function. This allows us to do procedures that were very high risk in the past or would not have been done in the past. Patients who have been turned down for surgery or do not want to undergo surgery now have additional options to be able to have their arteries fixed. The device, as I mentioned earlier, is placed through the artery on the top of the leg called the femoral artery. The hole that needs to be created to put the device in is a fairly large one, probably about the size of the tip of a pen. And the studies have shown that one of the main risks with the device was the bleeding at that site. At Englewood Hospital, we have been able to cut down on that risk of bleeding through meticulous pre-procedure planning, as well as meticulous access to the artery and the use of devices to close up the hole at the end of the procedure. We have been able to significantly cut down the risk of bleeding. Over the past few years, I'm proud to say we have had 0 bleeding complications. We have performed the procedure on people who have very low blood counts, which were felt to be too low for other institutions to perform the procedure. Studies have shown that bleeding during a procedure is a major risk for poor outcomes in both the short term and long term. As we have been able to optimize people before the procedure with our blood management techniques, as well as minimize the risk of bleeding during the procedure, we have been able to maximize people's outcomes. As I mentioned earlier, a growing subfield within interventional cardiology is structural heart disease. This deals with the valves of the heart and other structures within the heart. The advances that I will be mentioning include advances in the diseases of the aortic valve, the mitral valve, as well as helping patients with atrial fibrillation. The main two valve issues that people might have faced are what are called aortic stenosis and mitral regurgitation. The valves of the heart are like the valves of any other type of system. This valve opens up to allow the blood to go one way and then closes to prevent the blood from going the opposite direction. Both of these functions of the valve can have an issue with them. When the valve does not open properly, this is what is called stenosis. Instead of it opening perfectly well, it just opens minimally. When a valve leaks, this is what is called regurgitation. Aortic stenosis is when the aortic valve does not open properly and gets very tight and calcified over time. Mitral regurgitation is when the valve starts deteriorating and leaking and allowing the blood to go backward from one chamber to the previous chamber of the heart. For both of these valve issues, we now have minimally invasive methods to fix the valves while making a small hole in the blood vessel at the top of the leg and not needing open heart surgery to fix the valves. For aortic stenosis, the procedure that can be performed is called TAVR, or transcatheter aortic valve replacement. There are currently 2 valves that are on the market with additional valves that are currently undergoing clinical trial. These valves use a catheter-based system to replace the valve by going in through the artery on the top of the leg. It is a way to replace the aortic valve without having to undergo open heart surgery. The patient typically stays in the hospital for 1 or 2 nights and thereby speeding up their recovery. They're able to get up, walk around, and participate in physical therapy almost immediately. In mitral regurgitation, the tips of the valves do not come properly together. There is now a procedure called a mitral clip that allows us to place a device to bring these tips closer together. Also using a catheter-based system, we can now enter through the vein on the top of the leg and place the clip on the mitral valve and decrease the amount of leakage to the valve. Occasionally, people need more than one clip placed, and that can be placed during the same procedure. The patient usually stays overnight in the hospital and could go home the following day. This procedure also allows people to avoid open heart surgery to fix the mitral valve. For the TAVR procedure, it is now approved to be used in all patients regardless of their risk for surgery. For the mitral clip procedure, though, it is only approved for people who are at high risk for open heart surgery. More studies are being performed to look at whether lower risk people can safely have this mitral clip and thereby avoid open heart surgery. The last procedure I would like to talk about is called the left atrial appendage occlusion procedure for atrial fibrillation. Atrial fibrillation is an abnormal heart rhythm where the top chambers of the heart are not beating in an organized manner and are beating very rapidly and irregular. This causes a person's heart rate to be very elevated. It can also put certain people at risk for a stroke because the top chambers are not squeezing out the blood in an efficient manner. Through clinical trials, we have learned that approximately 90% of strokes with atrial fibrillation come from a small outpouching of the left atrium called the left atrial appendage. This outpouching has no clinical significance and utility that we are aware of. To minimize the risk of a stroke, people are typically put on blood-thinning medications. Initially, the only medication that was available was warfarin, also known as Coumadin. Since then, newer medications called DOACs have come out, such as apixaban, rivaroxaban, and Pradaxa, which all cut down the risk of bleeding. However, there are still people who cannot take these medications for a number of reasons, such as their risk of bleeding. There are new devices that allow us to close off that left atrial appendage and thereby removing the need for being on blood-thinning medication. The device is placed through the vein on the top of the leg and placed into the left atrial appendage. The heart then forms a protective layer over the device over the next few weeks. Most people only need to be on antiplatelet medication for a few weeks after the procedure. There are 2 of these devices on the market currently. The first is called the Watchman, and more recently, a second device called the Amulet has been released to the market. People typically stay overnight in the hospital after these procedures and then go home the following day. These are some of the newer advances and updates within interventional cardiology and devices that we use. These advances allow us to perform procedures more safely and in patients that would have been previously too high risk. They allow us the ability to have people avoid open heart surgery to fix narrowings and blockages within their blood vessels, replace tightened valves, and fix leaking valves. They also reduce the risk of bleeding, both from the procedure themselves and by reducing the need for the use of certain medications which may cause bleeding. Thank you for your time. I hope that you enjoy the rest of today's program.
Thank you so much, Dr. Schwartz. You've really enlightened us and we appreciate it. Well, next up on our program is going to be an interview. Ramon Correa, who's the manager of the Bloodless Institute, is going to interview Dr. Robert Simon. Dr. Simon is a board-certified urologist practicing in northern New Jersey. He specializes in minimally invasive techniques for prostate, kidney, and bladder cancers, as well as stone disease, voiding dysfunction, and urologic health. Dr. Simon is the leading provider in New Jersey for advanced therapies for overactive bladder and urinary incontinence. Other urologists throughout the tri-state area refer to him for the care of their patients. He utilizes several treatment modalities, tailoring the proper treatment to each particular patient. Dr. Simon is also one of the most experienced providers in the country of the InterStim sacral neuromodulator, which is a device to promote bladder control. In fact, he teaches doctors from all over the globe how to utilize InterStim in their practices. Dr. Simon's practice has been designated as a regional training center for sacral neuromodulation for voiding dysfunction of the bladder and bowel. This is one of only 6 centers in the country and the only one in the Northeast. Physicians from around the country and around the world have the opportunity to come and learn Dr. Simon's techniques that have been shown to dramatically improve patients' quality of life. After graduating from Emory University, Dr. Simon attended New Jersey Medical School and went on to complete his residency in urology at New York Medical College. He has also published several papers, presented at national conferences. Dr. Simon is an honored and esteemed physician with the Bloodless Institute here at Englewood Health and has been with us for many years. So thank you very much, Dr. Simon and Ramon, and we'll turn to you.
Thank you, Nancy. And thank you, Dr. Simon, for being with us today.
It's my pleasure.
You've been working with us 15 years now.
Yeah.
Time goes by quickly.
Way too fast.
Wow. And during that time, you've treated hundreds of patients from near and far. What a privilege.
It's been an honor. It's been a lot of fun.
And talking about treating patients as a urologist, I'm sure that a screening is a vital tool in finding and diagnosing conditions at an early stage. Are there any urological screening tests that you recommend, particularly for patients?
Sure. So for all patients, men and women, urologic issues can arise. One of the most common screening tests that are done at pretty much any primary care visit would be a urinalysis, where we're looking for not only if there's infection or irritation, but blood in the urine that can be an early warning sign for other things that are going on, as well as screening for diabetes and things like that in the urine. Some other screening tests that are very common, especially in men, is screening tests for prostate cancer, which is the most common cancer in men. As far as the testing and screening goes, for the men, specifically for the prostate cancer, we would start at the age of 45 and then go annually. For women and men, in screening for issues within the urinary tract, specifically on a urinalysis, that's with your regular primary care visit, and that can start really as early as you want. Starting in the mid-20s is probably preferable.
Excellent. Now let's go more specifically to certain conditions. Mm-hmm. Interstitial cystitis, which has an impact on a person's life, as you very well understand. What do you recommend regarding that treatment?
So interstitial cystitis is a condition, an inflammatory condition that is non-infectious, that causes a host of problems that have really been repackaged and put out as a painful bladder syndrome. It can manifest itself not only as pain, pressure, urgency, frequency, but can really impact somebody's quality of life changing them from a mild nuisance to really disabling somebody. So this is something that has really come to the forefront as something that we want to treat. We want to try to decrease any sort of flares, which would be recurrences of the disease, and going forward. So somebody that has a painful bladder syndrome would come in. We do certain exclusionary testing for that, and then there are a host of different therapies pharmacologically, as well as some surgical and invasive procedures for that as well.
And talking about frequency of urination, which obviously could be caused by a variety of different conditions, what are your concerns regarding that?
So frequency of urination has got to be the number one problem that urologists see across the country.
Really?
Absolutely, because it manifests from so many different disease processes and issues. It can be as normal as as a man that has an enlarged prostate, which is the exit of the bladder that can restrain urine and thus cause somebody to have the urge to go more often and have frequency, to somebody that has a urinary tract infection, to somebody that has interstitial cystitis, to somebody that actually could have a polyp or a bladder cancer. So these are the concerns that we have with somebody that has these frequency issues, and all of them should be ruled out and excluded through testing.
I see. Can you talk to us more about urinary incontinence?
Urinary incontinence is essentially the loss of urine when you don't want to lose it. Something that impacts over 40 million Americans. It is extraordinarily common, and based on its nature, it's extraordinarily embarrassing and very difficult for patients to bring up and to discuss their issues with it. However, if you look in any pharmacy, one of the most busiest aisles in the pharmacy is adult diaper aisle, and there's actually $14 billion of diapers sold every year for adult diapers, and adult diapers are actually outselling infant diapers. So it's something that impacts our society tremendously, has a huge issue with patients' quality of life and need for them to. Some people feel like they are slaves to their bathrooms and cannot go out. So it's something that we want to take very seriously and really try to improve patients' quality of life the best that they can. There are several different ways of treating it. We first start with behavioral modification, fluid management. Then there are a host of pharmacological and drugs that can be used for it. And then there's even a third line of therapy, which is more bladder specific and can be minimally invasive, where we're actually trying to do what's called neuromodulation and change how the nerves from the pelvis are communicating with the brain.
While we're on the subject, can you tell us anything about neuromodulation?
Absolutely. Neuromodulation is essentially trying to influence the nerves to help a patient out. And what we use it for is specifically bladder or urinary incontinence and urgency frequency, as well as retention of urine, where somebody that can't go to the bathroom, and then also in fecal incontinence or having bowel accidents and things like that. So this is a technique that is used in these conditions after somebody has failed or is unable to go forward with other therapies, specifically medication, physical therapies, and lifestyle modifications. So somebody that has gone through those types of treatments and has not obtained the results that they're looking for can be a candidate for neuromodulation, where we essentially do an in-office test. And what we're doing is we're testing those nerves to see if we can make an impact in somebody's quality of life. It takes 10 minutes in the office. There's no risk of bleeding or infection. And essentially, especially in urge urinary incontinence, where somebody has that urge to go to the bathroom and just can't get there in time when they're putting the key in the door, we see essentially 85% of those patients will have at least a 50% improvement in their symptoms. This is a technique that's been FDA approved for over 25 years now. There's been several improvements to the technique. There are over, I believe, 500,000 patients that have been treated by this technique, and it's something that we have really pioneered here at Englewood, and we do training of other physicians to learn how to do this technique, as well as bringing it to several other patients throughout the tri-state and actually the world.
Regarding us men, I understand that the older we get, the more we are concerned about enlarged prostate.
Sure.
What should we be concerned about or do?
Sure. So the prostate gland is a donut that's at the base of the bladder, and essentially you're urinating through that donut hole. And as we get older, the prostate can grow. And just as a donut gets bigger, that donut hole gets tighter and tighter, and it makes it more difficult to empty your bladder. So 1 in 3 men will experience some symptoms of an enlarged prostate. Those symptoms are typically decreased force of stream, urgency and frequency to go to the bathroom, hesitancy to go to the bathroom, being there online at the ball game and waiting for a long time. And then, of course, one of the most common is something called nocturia, or waking up frequently at night to go to the bathroom. So these are obvious things that can impact somebody's life to the point that if the prostate grows so large, it can occlude the bladder completely, and then you're up the creek where you can't go to the bathroom. So these are the things that we want to avoid and treat. And those treatments also can be anywhere from herbal supplements, pharmacological drug therapies, as well as several different minimally invasive and more invasive surgical procedures.
Excellent. And talking about the prostate, in the evening news and sometimes in internet, you hear mention prostate cancer with certain frequency.
Sure.
What should we do about it, or should we just wait?
Sure. Prostate cancer, like we discussed, is the most common cancer in men. It happens anywhere close to 1 in 7 men will develop prostate cancer. It's a little more frequent in men that have had a first-degree relative, a father or a brother that's had prostate cancer. Usually prostate cancer does not have any symptoms. There's no way to know, oh, something is going on with me. So that's when we start doing that screening test, that PSA, or prostate-specific antigen, that blood test, where we do it once a year, starting at that age of 45 and going forward. If that is abnormal, that would trigger some reason for us to go looking for whether somebody had prostate cancer. Now, just having an elevated PSA test does not guarantee that you have prostate cancer, and it requires a little more investigation. Also, a physical exam by your doctor, whether it's your primary care doctor or urologist, can also will also disclose whether there's a problem and needs somebody to go looking for it. Now, as far as treatment goes, a lot of it depends. If you do unfortunately get prostate cancer, there's a host of different treatments for it. And you're right, not all prostate cancers are equal, and so some of the prostate cancers are so indolent or slow growing and really are something that we don't even have to treat, and it's something that we would just watch. But these are the things that we would have to do to figure out after a diagnosis of the disease.
Excellent. I know you specialize in robotic surgery, and there's great success with that. But does everyone qualify for robotic surgery?
So robotic surgery is done with a robot that is called the Da Vinci robot, and essentially it is souped up laparoscopic surgery. So essentially laparoscopic surgery, where we used to make small incisions, a camera would go inside and we would manipulate instruments from essentially outside the body. Robotic surgery has been the new sort of improved method of laparoscopic surgery. And we've been doing robotic surgery for over 20 years now, and there's been several updates to that robot as well. We have the latest and greatest here at Englewood, and for the most part, most patients, specifically in the urologic field, are candidates for robotic surgery. Now, every patient is unique, and each disease process is unique, but we've made huge strides in urology of not only dealing with surgeries of the kidney, which is where the urine is made, surgeries of the bladder, as well as the prostate.
In addition to the robotic surgery, are there any other techniques or technology that are implemented here for the benefit of all patients, and especially those for whom transfusions are not an option?
Absolutely. So some of the techniques that have evolved over time have to deal with the use of different types of energy, so specifically laser therapy, where we are using lasers to remove tissue specifically in the prostate to make it easier for a man to urinate. This has a significantly reduced risk of bleeding, and that is really the primary reason why we use the laser. But we use that laser for not only bloodless patients, but that is the standard of care for all patients because blood management is important for everybody. So that has been a huge advancement in our field. There are several other advancements, including robotic surgery, which has decreased the risk of transfusion rates for a lot of these surgeries that we've done. You know, those are the two most issues that are foremost on my mind as far as things to help with the risk of transfusion.
Excellent. Dr. Simon, it's a privilege having you with us at our institution. Thank you for your time.
It's my pleasure. Thank you.
Thank you so much, Dr. Simon, and thank you, Ramon, for that enlightening interview. We appreciate it. Well, next up, we're going to have another interview. This time, our senior coordinator, Leilani Rangel, is going to interview Dr. James McGinty and our patient, Richard Lombardi. Dr. McGinty is Chief of Surgery and Surgical Services here at Englewood Health. In this role, Dr. McGinty provides leadership for inpatient and outpatient operating rooms, surgical staff, and programs with a focus on patient safety and efficiency. Dr. McGinty specializes in laparoscopic bariatric surgery, performing the full array of weight loss procedures, including revisional and gastric bypass surgeries, to help patients lose excess weight and address conditions associated with obesity. Dr. McGinty also performs advanced laparoscopic general surgery, including procedures to address hiatal hernia and other gastrointestinal conditions. He has a special interest in innovative surgical techniques and technology, including simulation and robotic surgery. After receiving his medical degree from Drexel University School of Medicine, Dr. McGinty completed his surgical residency at Allegheny General Hospital and his advanced laparoscopic surgical fellowship at the Minimal Access Surgery Center at New York Presbyterian Columbia University Medical Center. We appreciate your being here today, and we'd love to hear your interview.
Thank you so much for making time to talk today and to share your experience here as patients at Englewood Hospital. So, Rich, why don't we start with you? Tell us a little bit about what was going on in your life that resulted in you coming to Englewood Hospital.
Well, I was experiencing pain, I guess, for longer than I guess it had been for quite a while, and I thought it was muscle spasms and things of that nature. I mean, I had a kidney stone once before, but this was something on the left side that just appeared to be getting worse. One evening, I couldn't take the pain anymore. It was just becoming, I was doubled over in pain, and I said, we have to go to the hospital. It was like, I just couldn't take it anymore. It was hours of pain, and it wouldn't subside. So we, even though there's two hospitals closer, we just heard good things about Englewood and decided to go there.
Okay. And so you went to the emergency room and what did you learn?
Well, the emergency room was the professionalism of everything. They, our records came up that we were in the that we were bloodless surgery patients. We were Jehovah's Witnesses, and it was the even under the COVID atmosphere, everything was great. The precautions that were taken in the emergency room, a separate room, but they gave me something to alleviate the pain and I guess let things subside because I thought I was having something like diverticulitis. So they were able to stabilize me. They brought me in for a CAT scan. And long story short, they said, the good news is you don't have diverticulitis. So I said, wow, that's really good. But they said you can't leave the hospital because you need surgery. So I saw my whole life pass before me. It's not what I anticipated, and I was like shocked. I didn't know what to do.
Okay, okay. So they did refer you to Dr. McGinty for a surgical consult, and maybe you could tell us, Dr. McGinty, what was going on? What was Richard's condition, and what was going to be your approach?
Well, as it turned out, Richard had a very unusual hernia in the left lower part of his abdomen. A hernia is a hole in the muscle of the abdominal wall, and through this hole were his intestinal contents. His intestines were bulging through there, stretching open the hole and causing the pain. But this is more than just pain. The intestines were through this narrow opening and were at risk of blocking off or twisting and causing a blockage.
What made this an unusual type of hernia you mentioned?
Well, the typical hernias that we see in most patients are either around the belly button or down in the groin, called the inguinal canal. They account for a majority of the hernias that we see, or if a person has had a surgery in the past. But in this case, this was a hernia called a Spigelian hernia, and it's seen in only about 1 to 2% of the hernias that we see. And it's caused likely by the way you were born, where two overlapping layers of muscle failed to come together. So in this area, the muscle should be crosshatched like this, and there was probably a hole right in that area. And that weakness over time stretched to become wider and wider, and more of Richard's insides were pushing through that opening.
Wow. So it had been happening over a long period of time.
Yes, I'll share my screen here. This is the CT scan of the abdomen, Richard's abdomen. And just to take you through this, these light gray lines are the walls, the muscular walls of the abdominal wall. And you can see it's a nice continuous ring all the way around. And these other lighter gray patches are the intestines. And this is the hip bone here. So as we come down, you'll see that there's a break in this continuous line, and there's something abnormal that's, this is some fatty tissue that's bulging out part of the abdominal wall, and you don't see it on this side. And then as we come down here, you'll see why. There's a break right here. There's a hole in the muscle that you don't see on this side. And this is part of the intestines with gas and fluid in it that's bulging through that opening right above the hip pointer here, the anterior superior iliac spine. And as we continue down toward the feet, you can see more of the intestines bulging through there, and you don't see it on this side. And then it closes off, right? So that's the bottom part of the ring. And you can even see here that there's a line, and it's a little bit lighter colored, and that just talks about inflammation. That shows inflammation in the muscle and, or sorry, in fatty tissue around it. And right at the edge of this hole, this darker gray area is the urinary bladder. So the bladder was actually being pulled out through this hole as well. So this is just kind of gives you an idea of the size of the hole and what was pushing through there, and certainly could account for the pain that you're having, Richard.
And this was also fairly dangerous, wasn't it? With all the
Yes,
materials that were.
if you think of your intestines as a hose that's conducting all the food that you eat, if this gets pinched into a narrow opening, just like a garden hose, if you kink it, it will block off, and then that becomes an emergency, and almost certainly would have needed to be repaired as an open surgery, as a larger incision.
Richard, you also had a concern regarding transfusion. So, how did that factor in your decision to come to Englewood and to Dr. McGinty becoming your surgeon?
Well, through word of mouth and through what we read about, even though there's hospitals in the area that are closer that will agree to perform types of surgery with bloodlessly. Sometimes when push comes to shove, the patient is sometimes put under pressure, and yet when we came to Englewood, and even speaking to Dr. McGinty, who at length just took all the time needed to explain everything, blood wasn't even a consideration of being used. That the hospitals, all the doctors, the anesthesiologists, everyone is on the same page, which really takes that situation out of the equation. It really takes, not that there's not anxiety over surgery, but that's one thing that's out of the equation, that they're capable and clinically able to do it, and yet at the same time respect our beliefs, which are important.
Rich, you ended up not having surgery right away during that ER visit, but within a couple of months, you were back for surgery. What was your experience like when you came in for the surgery?
Well, first of all, the consult with Dr. McGinty was great. I mean, we weren't rushed out. He spent a lot of time explaining everything. So at that point, we felt comfortable. But when he came in the day of the surgery, and I was in the bed, and this was the bedside manner, but he could have just been talking down, but he sat on the bed next to us to really talk to us, which I thought was something like a friend would do. He explained again what would be taking place, to try and do it robotically, and that ultimately, if he wasn't able to do it robotically because of the size of the instruments, there would have to be a longer incision, which would mean possibility of infection or more recovery time. But and that, he felt confident that, because I asked him, do you feel confident in doing it? Because there wasn't a lot of material on this, but he said yes, and that even added more confidence, that we knew that either way it had to be done. But I thought what was really commendable, that as a good surgeon, he could have actually just done the surgery with the long incision, and it would have been taken care of. But yet going the extra mile for the benefit of the patient. And the follow-up visit, we gave him a hug. I don't know if I'm allowed to say that, but it was just like he was a dear friend that was able to perform this. It was a very successful and pleasant outcome for both of us. We had a lot of anxiety on both ends here.
Yeah. So it was able to be performed robotically, Dr. McGinty?
Yes, and it really worked out well. The surgery, from a technical perspective, the opening, the hole that was in the abdominal wall, was about 3 inches in diameter.
Wow.
And but the material that was pushing through that opening measured more like 7 to 8 inches of material. So like a mushroom, it was bulging through. So it took some time to reduce everything back inside to where it belonged. And as it turns out, there was another smaller hernia down in the inguinal region in the groin So we dissected all of that out as well, and then I was able to close the holes and put a large patch beneath the opening so that it would reinforce the repair and to deflect any pressure inside of the abdomen across the mesh and away from the hole. And we also use we work with our anesthesiologists and use pain control techniques to numb up the nerves that supply pain in that area, and to use other medications intravenously to help with that. So it couldn't have gone better. The robotic technology is absolutely amazing, in our giving the surgeon the ability to be more precise, to work in very narrow and tight spaces with a lot of precision and with great visualization, to the point where we're able to see the tiniest of blood vessels and to avoid them or to seal them before we cut them. And so the blood loss was quite minimal.
Yeah, I think I read it was 20 milliliters.
Yes.
Very
A couple
little.
of tablespoons. Yes.
Very good. So Richard, how's life now?
Life, we all know that, but the human body is frail, and there can be a lot of uneventful things that happen. But I feel like I've really got a new lease on life. I mean, I feel, in fact, she has to keep a lid on me because it's like 2 days after, I mean, I felt great. And it's like, each day is like, I cannot believe that I'm pain free. It is amazing. It's like Kathy probably gets sick of hearing me say it, but I feel so really good. It's like it is like a new lease on life. I don't have to worry about that pain anymore. I didn't realize until I look back how debilitating it was, and even from going places, because we didn't know at what point the pain was going to happen while I was driving or something like that.
Oh.
And then, for a few hours till the pain subsided, we couldn't do anything. So it's pretty, I'm very grateful to everybody involved. It's I mean, obviously, I'll be very frank. I mean, we did take the matter and pray about it as to, what should be done, and all things considered, we really are happy with the choices that we made. I don't think they could have turned out any better.
Very nice. Would you like to add anything? I mean, your perspective, as the wife of the patient, you're going through it with him. So what was it like for you?
Well, from the beginning, because this, due to time, this had been going on for at least about 4 years. So this pain and these incidents that he would have, the pain and using the hot compress, and that's why he said sometimes we just wouldn't go far away and things like that. So really, that evening that we thought it was diverticulitis, and going to Englewood Hospital, having the expertise, the radiologist, whoever read the CAT scan, identifying that, and then meeting Dr. McGinty, it was the best thing that could have happened, because it did get taken care of. He was so nervous. He didn't say just towards the end there, but he'd never had any surgery before, so no general anesthesia. Very afraid of that. Thought he was not going to make it through the surgery just from that. So yeah, we had a lot of anxiety going on in the house, and I'm trying to reassure him, but it was really Dr. McGinty and even the nurses on the floor when we arrived that day for the surgery, very calming, very reassuring. And by that time, Rich knew that the surgery had to be done because his life was just getting really impacted too much. So he accepted that, but he still had a lot of anxiety.
Well, I'd just like to say it was a privilege to take care of you and be involved in your recovery. It really, you have such a great positive attitude. I know you were nervous, but it really gave me a great deal of gratification to be able to treat you and help you and know that you're moving on and you're stronger and better than ever.
Yeah.
Yeah,
I
thank
mean, little incisions about
you. Oh, you can hardly see them.
like a little half inch or there. I mean, it's
Yeah.
just amazing for what had to be accomplished, and yet I'm really grateful. You know, the quality of life has really been enhanced by everything. Not only the surgery, but the recovery too.
Mm. Yeah. And I appreciated that you did put out the pros and the cons of everything. And even at that last moment when you were describing how long it was going to take, you said maybe 4 hours, and then you said, but don't get nervous if it goes longer. It doesn't mean it's going bad. I did really appreciate that, because at the 4-hour mark, I was looking at the clock, but then it still went another like 2 hours.
Wow.
Yeah, it was long, but I had that in my head. And you prepared me for it, and so I just knew that it was going well, really, that it was just taking longer. So thank you very much.
And he saw you afterward.
Yes, and he came out and saw me afterwards. So, yeah, very nice. Appreciated it.
Thank you again so much for your time today and for sharing your experiences.
My pleasure.
Thank you.
Thank you, Doug.
Thank you so much, Leilani, for interviewing Dr. McGinty, and of course, Richard Lombardi. We appreciate all of you being here today. Well, now, believe it or not, we're at the end of our program, so we'd like to invite Ramon Correa, our manager, to end the program. Ramon, please.
We hope that you have enjoyed today's program. We would like to thank today's participants, Jacqueline Papas, Dr. Margit Kaufman, Dr. Aaron Schwartz, Dr. James McGinty, and Dr. Robert Simon for taking their time to be with us today. Before you leave, you will have the opportunity to leave comments and questions for our coordinators. You can also feel free to let us know what other topics you would like us to discuss on our future programs. Remember, friends, we are available 24 hours a day, 7 days a week for emergencies. We are the Bloodless Institute at Englewood Health.